Hello, everyone, and welcome to the Georgia Recovers webinar for November, titled Beyond One Size Fits All, Understanding Medication for Opioid Use Disorder. My name is Ashley Narvaez, subbing in for Jayla Head, who is your usual host. Really excited to be with you all today to discuss this very important topic. So as you're all trickling in, please feel free to use the chat function to drop your name, where you're calling in from, the organization that you work for. Always like to know who's in the room with us. So I'll start with just covering a little brief agenda for you all today. Welcome and housekeeping. Then we're just going to jump into our intro slides to Georgia Recovers for anyone that's joining us for the first time. We'll go into speaker introductions and then the crux of our presentation. And then we'll wrap up with question and answer. To start off with some housekeeping, this webinar is being recorded, and a copy of the presentation and recording will be available on the Georgia Recovers website. We'll also be sending out an email with the link after the webinar. All attendees will be muted, but we do ask participants to use the Q&A panel at the bottom of the screen for any questions that they might have over the course of the webinar. The chat is also available, as I mentioned, for general commentary. The interpreter that is joining us today, Sarita Campbell, will remain spotlighted throughout the webinar. And to adjust your view and see all speaker panelists, you can click the view in the top right corner of your screen and then select speaker or gallery. And then users can also select side-by-side view. Please feel free to use the stream link to access the live transcription of the webinar, which we should be dropping in the chat. So just to go into Georgia Recovers, a brief overview of our campaign. Georgia Recovers is an evidence-based public health campaign aimed to reduce the prejudice and discrimination associated with substance use disorder in Georgia. The campaign is brought to you by the Department of Behavioral Health and Development Disabilities, DBHDD, and builds off the pivotal work of the Georgia Council for Recovery. We have three objectives. We're working to increase knowledge about substance use disorder and that recovery is not only possible, but probable. We're improving attitudes towards those living with and or in recovery from SUD. And we're also working to strengthen the capacity of stakeholders already responding to the crisis on the ground. In terms of our pillars of work, they are threefold. First and foremost, community connection. We will not be able to do the work that we do without the help of the community. Georgia Recovers connects with community organizations all across the state to strengthen our partnerships and to build awareness of the work that we're doing. And based off of that work, we also work with a group of community leaders, the Community Impact Committee, which we recently recruited for. And these community leaders really help to shape the work that we're doing with our campaign to make sure that our campaign is by and for the community. In terms of story sharing, our work is rooted in collecting and sharing stories of recovery from individuals who are in recovery themselves, their friends and families, allies, providers in the field, to be able to really humanize the disease of addiction. These stories are shared across all of our social media channels, along with our other stigma messaging. And in terms of education, the campaign is changing attitudes by promoting messaging that speaks to hope and recovery, the story sharing that I just mentioned, as well as the other content that we post on our pages. And then we also host monthly webinars to shed light on topics related to SUD. And really, a lot of these topics are rooted from what we hear in the surveys that you provide at the conclusion of our webinars. So lastly, if you're hoping to connect with us, we are on Instagram and Facebook. If you want to become a partner of the campaign or just learn more about our work, Jayla will drop the link in the chat so you all can connect with our online forum. And with that, I'll go ahead and introduce our wonderful speaker for today. Jamelia Hand is the owner and principal consultant of Vantage Clinical Consulting, LLC, where she provides strategic direction and training to healthcare organizations on opioid addiction topics. She's a professor, author, and treatment advocate for addiction and recovery issues. She serves on a number of boards, and she also speaks passionately to many family groups, treatment centers, and corporate organizations on prevention, addiction, treatment, recovery, advocacy, and opioid overdose. Her message always includes that substance use disorder is a family disease and should be treated as such. Her advocacy received the attention of the Illinois House of Representatives, and she was awarded for her advocacy in opioid overdose. For almost 20 years, she has taken great pride in being knowledgeable about resources to support recovery and has enjoyed being able to translate that excitement to anyone who will listen, especially students who are interested in working in the field of addictions or treatment providers who are experiencing burnout. So with that, I will hand it over to Jamelia.
Thank you so much. I really appreciate you for that wonderful introduction. I appreciate all of you who have come here today. Again, my name is Jamelia, and I am in the opioid use disorders. And let me put a disclaimer out there, right? Because we're all virtual. I haven't figured out how to silence notifications. So hopefully I won't receive a lot of emails while we're on this call. But if I should, please forgive me for any disruption or interruption to the presentation. Again, going back, I'm in the OUD and MOUD businesses, in part because a neighbor of mine, and her name is Miss Rose. And before we get started, I'd really like to tell you about her because she had such a profound impact on my life. I feel like I need to share her with you. So I grew up on the south side of Chicago. And again, there was this wonderful elder who lived across the street from me, and her name was Miss Rose. Well, Miss Rose was an absolute pillar in our community. She was well respected. She basically ran our block. Miss Rose knew everybody and she knew everything. And I'm sure all of you have a person that you grew up with in your community who had the respect of the community. She was block club captain. She knew all of the gang leaders. She also knew all of the local law enforcement. She knew how to keep everyone intact, and everyone was very respectful of her. There was absolutely nothing on her block that she couldn't fix. If anybody needed anything, they would call on Miss Rose. So let me take you back to 1979. Miss Rose was 80 years old, and I was the tender age of 6. Every Saturday morning, Miss Rose would come to her gate and she would yell for me, toy baby, that's what she called me. Come on now. Now, if you were like me on a Saturday morning, you were sitting in front of your television with a big bowl of what? Cereal, watching cartoons. However, when Miss Rose called you, you had to go. So on this particular Saturday morning, I abandoned my cereal, I ran across the street, and I did everything that I could do to make sure that Miss Rose was pleased with me. I had a really important job. Miss Rose's vision was failing, so I would thread her needles every Saturday morning. She sold clothing for her family, she sold clothing for the neighbors, she sold clothing for our community. So my job was really important to her. Fast forward a little bit, on this morning, it seemed like she had 100 to 200 needles, right? And so I sat on the floor at her feet, and while threading those needles one by one, she sang to me. Sometimes she would give me a few coins, she would give me a piece of candy. And on this day, after I completed my job, she stood up and she looked me down in my eyes and she said to me, baby, you are the best needle threader ever, ever. I can't tell you how excited I was, right? When I was done, I left out of the house, I ran across the street and I bursted through the door. And I said to my mom, Mom. And she said, well, what is it, baby? I said, I know what I want to be when I grow up. And she said, okay, what do you want to be? And I said, a needle threader. And my mom laughed so hard, she had tears in her eyes. And she said, okay, baby, whatever you want. Now, I share that story with you guys for a couple of reasons, right? But the most important one is Miss Rose made me feel so important. She had done something for me that could not be matched. Miss Rose was my cheerleader. And for people who are suffering from opioid use disorder, they need someone like you to cheerlead for them. They need a Miss Rose. They need an advocate. So I want to thank you all in advance for being a MOUD cheerleader and an advocate for your communities. Can I have the next slide, please? That was actually the slide we should have been on, but it's okay. Let's go to the next one. So today we're diving into a really crucial topic in the realm of addiction treatment, right? And that's the role of medications in the treatment of opioid use disorder, or what is referred to as MOUD. I'll use those terms interchangeably, but basically MOUD is medications for opioid use disorder. And this is a key area in our ongoing efforts to combat the opioid crisis. Now, I'm assuming that everyone on this webinar has heard about the opioid crisis. And one of the things that we would like to accomplish over the course of this webinar is we'll discuss the science. We'll explore very briefly, because we only have a little bit of time together, but we'll explore the brain. We'll talk about some of the different medications, and the differences in the medications used and the approach for treating opioid use disorder. And we'll also talk about how MOUD fits into the broader landscape of opioid use disorders treatment. After that, we'll delve a little bit into how MOUD can be integrated into a comprehensive treatment plan and treatment planning. And really, this integration is key for holistic care. And I want you all to keep that in mind as we go through the content. You guys mentioned evidence-based earlier in this webinar. You talked about community impact. And the way that we get there is through evidence-based holistic care. So we have to address that. Not only the physical aspects of opioid use disorder, but also the psychological and the social factors. We'll discuss some of the strategies for low barrier access to medications for opioid use disorder, and we'll also emphasize the importance of making these life-saving treatments accessible and affordable to all that need them. Finally, we'll tackle some of the stigmas, and we'll talk about some of the myths commonly associated with MOUD. I'm sure you guys have heard them all, so it won't be new information to all of you, but it may be new information to some. Because despite its proven effectiveness, MOUD is often misunderstood and even stigmatized. So we'll explore these misconceptions. We'll discuss how to educate patients. We'll also discuss how to educate families and even the communities that you live in. So I hope that by acknowledging these myths, we can foster a more supportive environment for recovery and hopefully enhance the overall efficacy of opioid use disorder treatment and strategies. Can we move on to the next slide, please? Let's talk about a little bit about what we know. So what do we know? I think that we can all agree that our opioid crisis is a national emergency, right? There are very few news stations that we can turn on without hearing something about the opioid crisis. It really is a critical issue that's facing our nation. It's more than just a health problem, it's a societal crisis, and the impacts are both far and wide. And so to provide an overview of the data, drug overdoses are now the leading cause of accidental death for Americans under 50. Last year, with an astonishing 107,081 lives lost. And that every time I say that number out loud, it hurts my heart, honestly. This number isn't just a statistic. It represents individual stories. It represents families. It represents communities. It represents people like us and families like ours who were deeply affected. And across the nation, we have 2.5 million people who are grappling with the consequences of this crisis. And did you all know that less than 10% of those get the help that they deserve? Out of 2.5 million people, less than 10% get the help. I want you to make a mental note of that and even write it down if you need to, because this is profound, right? The economic burden alone is staggering. I believe it's somewhere in the 78 billions. This includes healthcare costs. It includes lost productivity. It includes addiction treatment, criminal justice involvement, and the list can go on. I'm sure you all have some others that you can actually add to that list as well. But digging deeper, it has been found that two-thirds of opioid, excuse me, two-thirds of drug overdoses are attributed to opioids, primarily fentanyl, right? And this is a potent drug, and uh, it's used non-illicitly in healthcare settings, but it's often used illicitly in substances. So the crisis has overwhelmed all of us. It's overwhelmed emergency departments, and with the significant increase in visits related to opioid overdoses, this is not something that we can continue to ignore. And perhaps one of the most heart-wrenching aspects of this is the fact that there has been a five-fold increase over the past 20 years in neonatal opioid withdrawal syndrome, or NOWS. And this is where babies are born into withdrawal. I often hear the phrase that babies are born addicted. No baby is born addicted. Babies are born displaying withdrawal symptoms, which is sometimes a consequence of opioid dependence during pregnancy, right? So let's face it, this issue extends beyond health. We are dealing with loss, we are dealing with trauma, we're dealing with grief, we're dealing with homelessness. The list goes on. And opioid use disorders are a growing concern that require our immediate, sustained attention. So put exclamation points behind all of that: immediate, sustained attention. It's a multifaceted issue, and we need to throw everything we have at it. We need a multi-pronged, and I know you guys probably hear that word a lot, but we need a multi-pronged, comprehensive approach which combines not only medical, but also a social, policy and advocacy driven solutions. Next slide for us. Thank you so much. So let's talk about objective one, right? One of the reasons why we're here. So as we dive into this really fascinating world of opioid use disorders and the incredible science behind treatment, and again, today will be an overview. That's really a complex topic, but it's incredibly relevant to the work that we're doing and also to the communities that we're serving. So let's get started. So what exactly is an opioid use disorder? In simple terms, it's a condition where someone has a lot of difficulty controlling their use of opioids. This could be prescription painkillers, it could be illegal drugs like heroin, but in short, this condition affects the brain and the behavior, leading to an overall inability to control drug use despite harmful consequences. So no matter what someone does, they just can't seem to get it together. You'll hear people say that often, who are suffering from opioid use disorder, that they can't get it together. So why does this happen? Well, in the brain, opioids bind to receptors, right? These receptors are located in various places in the body, but in the spinal cord, they disrupt the pain signals. And so when they do this, they release large amounts of dopamine, which is really the feel-good chemical, right? And this feel-good chemical not only reduces pain, but also creates a strong sense of euphoria, or what we know as a high. And over time, the brain starts to need more opioids to achieve the same effect. And this is called tolerance. And over time, tolerance leads to dependence and eventually addiction. And I'll share a personal story as an example. My father, when I was very young, as a matter of fact, at the age that I was being cultivated under Miss Rose, my father was a victim of gun violence. And he was shot in a very precarious place, a place where if they had taken the bullet out, they would have also had to remove his pancreas. Well, he elected against that. He kept his pancreas, but he was in a lot of pain all the time. And because he was in pain all of the time, he was also prescribed opioids, right? And over time, taking the opioids, he became dependent on them. And the dependence crossed over into dependence. And the dependence led to a lifelong battle, for the entire family. And unfortunately, he passed away in 2010. However, one of the things that I sought to understand was learning more about the brain and why this euphoria or why this addiction was taking my father from our family. But throughout his journey, he did get some treatment, right? And there were, in our case, three ways that people who are suffering from opioid use disorder usually seek treatment. There are three FDA approved medications, and those medications are really game changers, right? They are game changers in treating opioid use disorders, and they are called methadone, buprenorphine, and naloxone. So methadone has been around since the 60s. It works by changing the way that the brain and the nervous system respond to pain. They lessen the painful symptoms of opioid withdrawal, and they block the euphoric effects of opioid drugs. It's like a substitute teacher, right? It takes the place of opioid without causing a high. Buprenorphine, on the other hand, is a bit newer. It works similarly to methadone, but it has a less potent and a lower risk of addiction. It basically tricks the brain into thinking it's getting the opioids that it craves, which helps them to ease the withdrawal symptoms and the cravings. And this is exactly what people require to get better. They need that brain to slow down. They need the withdrawal symptoms to be managed. They need the cravings to subside so they can think and they can be. Now, Trexone, last but not least, this one works a little bit differently. It blocks the opioid receptors in the brain. So if a person relapses and takes opioids, they won't feel, their usual high. So it's like putting a lock on the brain's opioid receptors. And when we integrate treatment into all of this, the broader landscape of addiction can be addressed, right? These medications, buprenorphine, methadone, and naltrexone, they help us to mitigate the overwhelming noise caused by the brain. And this noise manifests itself, again, in intense cravings, withdrawal symptoms, and a preoccupation with obtaining opioids. So, in essence, medications provide a foundation upon which a comprehensive and holistic treatment plan can be built. They don't work in isolation, but they are part of an approach, and they address both the physical and the psychological aspects of addiction. And again, I can't say this enough, by quieting the noise, the medications can help patients to actively participate in their own healing journey. They lay the groundwork for long-term recovery and overall well-being. Can we move on to the next slide, please? Okay, so let's talk about how medications for opioid use disorder, or MOUD, can be integrated into comprehensive treatment plans, right? And we also talk about a few strategies in regarding low barrier access to these medications, because it's really important that we make these available to patients, and there are a number of ways that we can do that. So for MOUD, again, there are three FDA-approved medications: buprenorphine, methadone, and naltrexone, and each of these are used to treat opioid use disorders. Again, they reduce cravings, they block the effects of other opioids, they help patients to manage their withdrawal symptoms. But the goal here is not just to treat the addiction, but to provide, again, a holistic and stable platform for overall recovery. And so as we integrate MOUD into treatment plans, it means that we have to look beyond the medication. When we're using MOUD, We're again quieting that noise. And if I hope I've said that enough so that it sticks, because this quieting allows the patients to engage better and other treatment aspects. It helps them to seek and stay in counseling. It helps them to receive the education that is being given to them. It helps them to participate in the programs. It helps them to build skills. It helps them to participate in activities. And the efficacy rate is good, right? The efficacy rate for someone who utilizes MOUD and counseling is about a 74% at year one. However, research also suggests that buprenorphine and methadone work just as well at reducing opioid use without counseling as with it. So that's something to keep in mind, right? One of the things that we also have to recognize is that we have to stabilize the patient long enough to introduce the help that they deserve. That's so important. When we create a plan, we can actually envision moving forward, and so can they. And it's important to tailor these plans to each individual. Someone might benefit from cognitive behavioral therapy, if you've heard of that. Another might find group work really supportive and helpful. The key to MOUD is that it's a foundation. We get to build on it. Once we set that foundation and we cement that, we build upon it with the therapies that address the psychological, the social, and the behavioral aspects of addiction with as few barriers as possible. So let's talk about low barrier access and what this looks like. Again, this is making MOUD easy or easier for those who need it. Traditional models often put up barriers. There is, and I used to be a practicing counselor. One of the things that I can remember is just the amount of paperwork. Not only the amount of paperwork for me, but for the patients. Oftentimes I would have patients that would take, 2 and 3 buses, and then they would walk to get to me. They would have to do this, and they would go through so much trouble to get to me, only to be met with a stack of paperwork, right? And intrusive questions. We really have to take a look at our approaches. There are also long waiting lists or even stringent criteria. We need to shift that, and we need to work collectively as a community, our community, everyone on this webinar. We need to work to shift that. And so one approach is to have same-day prescribing policies, right? Let's say we have a patient that comes in to the treatment center and they're in withdrawal. The last thing that they're thinking about and that they would be effective in is sitting through a huge binder of paperwork. We need to make sure that people can get medication the same day, right? This means that a person can walk into a treatment program, they can get assessed, they can get a prescription on the same day. Another strategy is integrating MOUD fully into primary care settings. And there are many physicians nationwide who are implementing buprenorphine or Suboxone, as many of us know it, into their primary care settings. So if it's accessible and patients are able to get buprenorphine as they are any other medication, then it falls into a criteria of standard. People see it as the norm. It's not a big deal. It's not us outside of the box. It's us doing what we already know to do. We screen, we assess, we diagnose, and we treat. Another thing that we can do is we can advocate. We can advocate for mobile clinics, right? Mobile clinics and even telemedicine, especially in rural or underserved areas. And we have many communities that just don't have access to anything. So once we get these things within communities, mobile, telehealth, day treatment, same day prescribing, it becomes as accessible as getting any other medication then the treatment goes to the patient, not the other way around. We're not running the treatment, the patient is running the treatment, and they can get what they need in their time, the way that fits into how they live. And of course, there are stigmas attached to this, right? And we'll get into this more a little bit later. But stigma is probably the biggest one because there's still a lot of misunderstanding about addiction and the use of medications and treatment. And one of the things that we can all do is we can educate. We can make sure that people are aware. This is really key here. We need to break down these misconceptions and advocate for evidence based treatment so that we can make a bigger community impact. And finally, another challenge is just ensuring what we call in provider and in clinical services continuity of care. And this means that we don't stop at prescribing, right? After a physician's write a prescription, there's also ongoing support, or there should be ongoing support. We should be providing ongoing support as a community. We need to make sure that patients stay engaged in their treatment journey. We need to make sure that they have resources available to them so that they can do just that. We have to be willing to see things through. The longer that someone can refrain from harming themselves with problematic drug use or illicit drug use, the more that they consider the more that they can consider a life free of drugs, the more that they can consider a life that is, spending time with their family. This is the whole holistic approach and journey to recovery. And by lowering these barriers, right, we can ensure that those who deserve and need desperately these life-saving treatments, they can get it and they can get it easily and they can get it quickly. Next slide, please. Thank you so much. So a vital aspect of treating opioid use disorder is obviously the role of addressing the stigmas and myths, right? Hold on one second. Okay, I just wanted to make sure I was looking. So the stigmas and myths have a significant impact on whether or not someone will seek, receive, or stay in treatment, right? I'm sure we've all seen it before, right? There are significant barriers. They impede successful implementation of treatment. They lead to misunderstanding. They lead to fear. They lead to resistance among patients, resistance among healthcare professionals, and even within the broader community. So overall, it's this resistance that hinders those in need from accessing life-saving care and support. So what can we do? What can everyone on this call do? Well, one key, of course, is targeting education and awareness. And that's what we're doing today, right? We're here together because we want to get educated and we want to become more aware. And when we do awareness raising efforts like these, it's essential to reach out to different groups involved. These different groups consist of, I'll deal with three primary groups for today. We'll look at the patients, we'll look at the providers, and we'll also look at the community. So regarding patients, how can we educate patients on the safety, on the efficacy, and on the importance of MOUD? And how can we alleviate their fears or help them to alleviate their fears and encourage them to seek and adhere to treatment? This is a question that I have for all of you. You don't have to answer it now, but this is something that I hope you'll think about, right? Because this is important. Also, providers, healthcare providers need accurate, they need up-to-date information on MOUD. They need to work with their managed care organizations who provide reimbursement. They need to understand the benefits. They need to understand, I don't know if there are any counselors on this call, but they need to hear from you. They need to learn from you. They have spent a lot of time becoming healthcare professionals, right? but they haven't spent a lot of time becoming counselors. And in medical school, they get a very limited introduction and experience when it comes to addiction treatment. So you actually have an advantage and you have something to say. One of the things that I would do very frequently when I was a counselor, especially if there was a provider in the community that I was working in that I was concerned about. And when I say concerned, that means that I will find several patients seeking opioid use disorder treatment, but they were seeing a specific doctor. So to me, that said, well, maybe this is a great opportunity to have a conversation with the provider, help them to understand some of the patients concerned, and even how to combat their own biases and misconceptions. And out of this came some really fantastic conversations. And last but certainly not least, the communities. Communication and community level education is vital. Part of that is dispelling the myths. We have to highlight the realities of OUD. We have to showcase MOUD as a critical component of treatment. And we have to work collectively and as a team. And I consider everyone on this webinar part of the treatment team. We together can foster a supportive environment for those who are seeking help. So let's talk about what gets in the way, right? Some of the stigmas. What are some of the patient's concerns? We have the fear of replacing one addiction for another, right? How many of you have heard that this is a crutch? MOUD is a crutch, and you're just trading one drug for another. Patients believe this, but they don't understand the pharmacological differences and the controlled therapeutic nature of MOUD. It's up to us as advocates and clinicians and educated community members to help to dispel that myth. In some cases, it's perceived as a sign of weakness. Some patients view the need for medication assistance as a personal failure or a lack of willpower. You know, the research has dispelled that myth. So it's important for us to talk about the research so that we can help people understand that this stigma is not helping the patients that we want to get well. Also, there's a misunderstanding about treatment duration. There's a common belief that MOUD is only a short-term solution, and it doesn't contribute to long-term recovery. If we think about it this way, the longer someone can practice good skills, the better they get at those skills and the longer they can retain those skills. And then it becomes a way that they are. It becomes a way of their everyday life. And it's not something that they have to be intentional on doing. It becomes part of their fabric. So we have to be okay with allowing people to be on medications for opioid use disorder as long as they need to, so that they can build the skills and they can seek and or obtain long-term recovery. From a provider perspective, they have concerns about misuse and abuse, and that's fair, right? Providers often worry about the potential for medication diversion. And sometimes this influences their prescribing practices. Also, a lot of them just lack familiarity with MOUD. They may not be fully informed about the effectiveness. They don't learn a lot about this in medical school. That's just being honest. And when they don't know, and like any of us, when we don't know something, this leads to hesitancy. It leads to hesitancy in prescribing or even recommending some of the treatments that research supports. And also, they may be an abstinence-only provider. You know, a belief is still held by some providers that abstinence is the only way to go, and that somehow abstinence is superior to pharmacological interventions as opposed to potentially introducing both, because they can actually work together to enhance outcomes. And finally, from a community perspective, goodness, I'm not gonna spend too much time on this, but these are some things that we've heard, right? The whole "not in my backyard" concept. I can't even count how many communities have been absolutely resistant to the establishment of clinics that provide MOUD in their communities, somehow thinking that there will be a decrease in neighborhood safety. There's also stigma against substance use disorders, thinking that this is somehow a moral failing rather than a medical condition. And this does not help communities. It keeps people in fear and it keeps people from getting help. And they just don't understand the way we do, right? They don't understand the effectiveness. And so we have to be aware and we have to be willing to share that there is scientific research to support the effectiveness of medications for opioid use disorder treatment. And this leads to the reduction in skepticism about its role in treating MOUD. So once we address these myths, we can improve access and we become part of the solution. We contribute to the overall effectiveness of MOUD, but as a part of a comprehensive treatment approach, right? Education, awareness raising efforts like these, targeting patients, speaking to our providers. Get out and talk to your providers, please. They need you. And if you are more knowledgeable in this space, as they are, offered to go by their offices and do in services. I would do that all the time. I would say, hey, you know what? I'm a counselor and I, went to school for this and I'm really passionate about speaking about the treatment of opioid dependence and opioid use disorder within my community. And I'd really love to come in and educate your staff, whether it be your nurses, your medical assistants, your office manager. Everyone deserves to know. And the more people know, the more they can be open to resources that are available to the patients that they serve. If they are somehow without the knowledge or if they are withholding information, that's not holistic. That's not a whole person approach. And it's not giving people resources that are available to them. So let's work together to try to do that, right? Let's go to the next slide, please. All righty. Oh gosh, time is flying with you guys. Goodness gracious. Um, okay, so we're at the wrap up phase, right? So to wrap it up, I really want to leave us all with a I want to leave us with a critical understanding. Sorry about that, you guys. And a critical message about opioid use disorder, right? Uh, Early on, I think that Ashley said that people can recover and people do recover. And that's true. You know, opioid use disorder is chronic. It is. It's like any other chronic disease. It's chronic. It often involves relapse. It involves management, but most importantly, it's treatable. And the good thing is that we have treatments that are available for people. There is help, there is hope. People can and people do recover. So, as we look at opioid use disorder as a comprehensive approach to treatment, is complex, right? It requires comprehensive treatment planning. Again, this is not just about managing the symptoms. It's also about addressing the root causes. It's about providing that holistic support. It's about being a Miss Rose, right? Clients in OUD treatment need an approach that encompasses both the pharmacological therapy and the social and psychological supports that patients deserve. We have to throw everything that we have at this. We had 107,081 deaths last year, and we have resources to mitigate that. So let's do what we can, right? The role of MOUD and other medications and what is absolutely central to this treatment is an effective treatment plan, right? Uh, Medication is key. Medication stabilize the moods, it manages the withdrawal symptoms and the cravings. But what about giving the mind and the body a plan to heal? And that's what we do when we create a comprehensive treatment plan. And those obviously a provider is going to implement the plan, but you, as part of the overall treatment team, they can't do it without you. So I don't want anyone walking away thinking that you don't have a role, because you do. Your role is as a supporter, your role is as an advocate. Your approach should be grounded in strength, right? I don't want to preach to you guys, and I'm certainly not here to do that, but we have so much that we can offer, right? We can look for strengths. We know that people recover. We see it in our work. We see communities beginning to heal. And we have the privilege of always looking for assets in this situation. We always have the ability to look for possibility. We have the ability and capacity to look for strength in areas that other people just can't see it yet. So what can we do as a community, as part of the unofficial treatment plan, to make sure that we're raising and that we're looking for the assets that exist in every area? You know, if someone overdosed and survived, that's a success, right? And that's also an opportunity to introduce a new way. You know, I don't think that anyone wants to die, you know, from opioids. I know my father didn't. He didn't want to leave his family. He loved his family. He loved me. He loved his children. He loved his wife. He wanted to be a good citizen. He was a hard worker. He wanted to realize his dream of becoming a nationwide entertainer, but he just couldn't figure out how to get there, right? And as supporters and and advocates, I think if we had lived in a community that supported his recovery, we lived in a community that supported his strengths and were able to share those things with him, uh, we could have collaboratively helped to heal him and others within my community who were recovering from the same thing. So we got to be there for each other, you all. We're a pillar of support, again, not just for patients, but for each other, because the collective community mental health diminishes every time we have an overdose. So collaborative support is crucial. It's absolutely crucial in this journey, and we all have a role in that. And we also have to educate and support families. Uh, how do we focus on educating families, right? One of the things that we can do is we can take whatever knowledge we gain, uh, whatever resource we know, uh, whatever tools we hear about, and we can share those with the community. And this includes access to overdose antidotes like Narcan, right? If you guys don't know about Narcan, Narcan helps to reverse opioid overdoses. Most communities have a harm reduction program or a local health department where you can probably go in and get Narcan for free. But this is something that you can definitely look up online. So when we leave this call, go and Google free Narcan in my community. Get yourself a box, get yourself trained, and teach others in your community how to do the same. So, in conclusion, you all, um, treating treating opioid use disorder, and I know I've said a lot, but really, I think I want to leave us with the fact that it really is about more than just addressing the physical symptoms, right? It's about creating a supportive network, which we have here. It's about educating, it's about advocacy, it's about empowering patients, and it's also about being a resource of support for their families, right? It's about hope, it's about help. It's about working together to really overcome this challenge, you all. So I thank you all for being part of this, an integral part, not a part, an integral part. I want to emphasize that of this effort. And I thank you for sharing time and space with me today. Now we can move on to questions. Thank you. Next slide, please.
Thank you so much, Jamelia, for speaking with us today. I was really moved by all of the personal stories you shared, especially that of Miss Rose. I loved that. And now we'll dive into some questions that our audiences, had for us. And one of the ones that came in, and this is more talking a little bit about the logistics of MOUD and how that can be integrated into, healthcare systems and within clinics. But how expensive are these medications, along with counseling? How do clinics get, paid? What does that system look like for, clinics that are interested in offering these services?
Well, the good thing is that, I, I would like to say that communities have really worked diligently to provide greater access to medications, right? So healthcare providers and clinics are paneled with managed care organizations, right? So these medications are reimbursable. The provider time is reimbursable, and the medication is reimbursable. And for most patients, especially if they're on something like a Medicaid or Medicare, they only have to pay a few dollars out of pocket. Now, as part of my role as a consultant, I have helped many, many, many clinics to set up their infrastructure um, from the ground up. I work with everyone from the receptionist, to the back office, and we put together infrastructure and policies and workflows, and we get paneled with managed care organizations. But this is a very different world than it was back in early 2000s when these medications were new and no one had heard of them and nobody wanted to pay for them. So at this point, the medications are covered. The provider's time is covered. It's just about organizing your office and streamlining the everyday tasks so that you can maximize on your reimbursement. It's not impossible. So feel very, very hopeful that it can be done in your office or clinic. And with people, who serve in the capacity I do, we can give you some tips and some tricks and some best practices in that area.
That's certainly good to hear. And just
Mhm.
jumping off of that a little bit when talking about how to set this up in your practice, but you talked about barriers as well.
Yes.
And so, especially when we think of underserved areas or rural areas who have less, access overall,
Mhm.
can you think of any strategies for communities to come together to try to reduce some of what that may look like?
Yes. So, it starts here. It starts with everyone on this line. I'll give you an example. So I was part of the US launch team for Narcan nasal spray. And I also work for the manufacturers of buprenorphine. I worked for both of those companies at one time or another. And I was at the beginning, and it was at the beginning, it was at the launch. And we had to go in communities that not only had not heard of what we were trying to do in the medications, but they just didn't have a lot of resources. So one of the actually, I mentioned a couple of ways earlier on how we can work together to increase availability overall. And if I'm not mistaken, that's where you're going, right? Just how we can broaden availability
Yeah, that's correct.
and how we work together to do that. Telemedicine has really, oh my gosh, telemedicine has just been wonderful. and the government, the flexibilities surrounding telemedicine are still available to all of us. So, especially in underserved or rural areas, telemedicine plays a vital role. Healthcare providers can offer online consultations and follow-ups, and this can make treatment more accessible. Community education programs. I don't know where all of our attendees are from, but it takes one person to set up an educational program, to pull resources together and make them available for a community and build a simple one-page, website where people can access, and even running educational platforms to inform the communities about the benefits of treatment in addition to MOUD. These also help to reduce stigma, right? The more information that we can get out there, the better we can ensure that this is not foreign to people, because people tend to judge what they don't know about, and that's not a good thing. But that's how it happens, right? So, as we seek to develop telemedicine services, community education programs, again, mobile clinics, I spoke a little bit about that earlier, partnering with other local organizations. You're not in it alone. Someone cares about this issue just as much as you do. You just have to find them. And once you all come together, you can partner with community churches, community based organizations, schools, community centers, and you can pull together all of your resources and make those available to the community. And lastly, advocate. Do what you're doing today. Advocate for policy change. Make sure that you advocate for changes in your local communities, within communities that are hardest hit and have few resources. This is how you get the word out, because that increases funding and it also increases support for programs that would like to treat opioid use disorders with medication.
Thank you so much for that. I think
You're
just
welcome.
time for one more question on our
Sure.
end, but you talked a little bit about this in your presentation. But when it comes to thinking about comprehensive treatment plans for individuals, what other support systems should be in place or can be in place for individuals that are, using MOUD at the same time?
So many believe that it's that the medication, plus the counseling, including comprehensive treatment plan or comprehensive treatment planning, is the key. And in addition to that, and I'm not necessarily promoting this, but sometimes it takes a minute to get people to actually go into counseling. So if we can still make the medications available to them until they get to a place where they understand that counseling has benefits and they decide to enter into counseling, uh, we still need to make the medication available. So, counseling and behavioral therapies are wonderful. They help to address the psychological aspects of addiction and even teach coping strategies. Also, peer support groups. Support groups are amazing. And some peer support is actually reimbursed by managed care organizations as part of holistic healthcare, right? These can be invaluable. Also, vocational and educational support, right? Assistance in these areas can help individuals to rebuild their lives while they're also getting care. So the simultaneous service delivery approach can be really helpful. And finally, just monitoring and follow up. We, it's easy to prescribe, to screen, assess, diagnose, and prescribe, but it's really the follow up and helping people to work through some of the issues that led to what what led to their addiction or their dependence on the medication, and making sure that that monitoring is continuous and that we're timely addressing the concerns that they have. um, this helps us to address issues that they're facing as they seek recovery. So those are some things that are in addition to the holistic and comprehensive treatment approach, treatment
Yeah.
plan process.
Thank you so much for that background and that context.
Mhm.
We are right at time. Thank you everyone for joining us today. Once you log out, and Jayla just dropped the webinar survey in the chat, please feel free to complete that. We really value the feedback that we get from you all. So with that, it was really great seeing you all. Thank you to our wonderful interpreter and our wonderful speaker and everyone else that helped with this webinar. Have a good rest of your day.